Hello, everybody. Good afternoon, good evening, or good morning to all our colleagues of medical physicists everywhere. This is Ibrahim Duhaini, the moderator for this session. As you all know, we are doing multiple seminars during, the year, and we have two seminars during the summer. Although people are taking their vacations, but we still have some people are eager to learn even in the summer vacation. So I would like to welcome every one of you. And of course, I would like to welcome our speakers and our coordinator, Dr. Magdalena Stavia, who will be coordinating this session. And this session will be recorded so that if anyone would like to go back and see the recording is welcome to see, and this will be posted in our website. It is my pleasure to present to you two prominent speakers, one from the States and one from India, two parts of the world, very good colleagues of us, very experienced medical physicists. And our topic is about the advancement in imaging in radiation therapy. And as you know, like 20 or 50 years, from now, the radiation therapy will be very advanced. But before, we used to have, the film. If you still remember from, the old times, we used to take photos, films for the patient before treatment, wait for the films to be developed. The physician will see to approve the patient, the imaging before we go and give the treatment to the patient. Nowadays, because of the advancement in technology, all this is going into a faster pace. And today we'll learn how these imaging techniques helping, cancer patients to get their treatment correctly and without any errors. So join me to welcome Dr. Hassaan Alkhatib, who is the Chief Physicist at South Carolina Oncology Associates in USA. He has more than 30 years of experience in this field. He is board certified with ABR and AABMP, and he participated in many AAPM educational and professional activities. And he is also an author of many scientific publications. Today, Dr. Hassaan will talk to us about the evaluation and quality assurance of X-ray-based IGRT imaging system based on the MPPG #1, who was part of this group to advance in imaging technique. Hassaan, the floor is yours. Would you please share your presentation and we can start.
Good morning, good afternoon, good evening. I'm going to, show you the slides, but I'm going to go off the slides a little bit, give you some history, but I'll do it fast because we don't have enough time. This group was formed somewhere around 2008, but we started using like cone beam CT IGRT in 2007. We did a lot of work with Princess Margaret. This presentation was shared by many of us in the next group. So this is, again, the evaluation, the whole task group, I think it's called 225, TG 225 now. But it is to evaluate the quality assurance of X-ray based just for radiotherapy system itself. This is the people. Jonas was the chair, and he is at the Mary Bird, and then we have many other colleagues. And we did.
Sorry, Hassaan, if you are showing on the screen, please share the screen first.
Oh, sorry.
Yeah, just to remind you.
Share. You see it?
Yes.
Okay, so
yes.
sorry. I'll go back one, so I just show you I don't miss anything. Okay, so again, this is the talk, the name of the talk. This MVG number one is really now it's called TG 225 in the AABM, and all these experts we work together to come up with some recommendation. It's like a recipe for this new technologies that coming into use in our department in radiotherapy. Now, as Ibrahim said, before we used to take pictures, and I'm going to next slide. I think it is exactly what he says. However, this I divided the talk into section. I'm going to give you some introduction, definition, and of course, with the introduction of this, it is so many things we have to do. We have to divide to different teams to do different tasks. Otherwise, it is important that we have a team effort to come up with a good results. And then, of course, at the end of the talk, we'll have a minimum recommendation, and then we'll have a conclusion. So now, again, so this is what Ibrahim was talking about when we do a breast under fluoroscopy. The physician used to do 2 wires at the entrance in the middle next to the sternum and one above the muscle in the lateral side. And he would do a fluoro, and when the wires come in one line, they are aligned, then that's our entrance, and then he would go to the lateral side, do the same thing, and then once they aligned, that will be our exit, and then the other lateral beam. And it worked, it was fine, but as you know, then we found out there's a complication of sparing, especially for heart and for different lung, liver, all kinds of things. So we need to come up with something more advanced to spare and to the quality. Yeah, we did the cure, but sometimes we have complication due to increased dose to heart and other stuff. And there's part of above the heart, next to the left breast, it's called the LAD. That's very important that we did not pay attention to, and that's what causes some complication, major complication, really. So here is the first IGRT, which is a cone beam CT, and most of the work I did was done on elected machines. And so you have, it's a very nice system. And of course, it comes with all the tools and how to fuse, and it has to be fast enough that when you do it, the patient is on the table. You don't have time to spend more than a few seconds, really, because the more you sit on the table, do you have bladder fill, rectal fill, and that changes the position of the prostate. And your gland that you intended could be delivered in a different way, which could be damaging, and it could have some complication from day to day. So therefore, it has to be a robust system, but at the same time, we have to have rules. We have to have some kind of recommendation or requirement of, okay, we're doing a prostate. Most of the clinics start using it in the United States because it was very rewarding financially, and we do it every day. Well, we have to worry about what is the dose that the patient gets when you do a cone beam CT, and we'll talk about that. So we did a lot of measurement. You have a variety of energies that comes with this MV-KVB system, and you need to know exactly where to use, like head and neck. You have a different technique, the energy and the resolution and all these kind of things. So you minimize the dose, but you still want to have the confidence of aligning the organs, whether the BTV or the organ at risk, in a very good way. That way, the intended delivery, the plan is delivered the right way. And so it is not as simple as is, and there is so many different parts of the system that need to be tested. And that's when we start talking about it. It took us a while to come up with a nice report. However, we did a lot of tests. It took me 40 months to come to analyze and give data, and it took typically every time we do a GRT test from end to end and on a monthly basis, about 5 hours. But I tested every part of the system, and I recommended that, but the whole group shut me down, and they said that's it's not fair to the physicist. And now I understand. I was younger then, but now I'm older, wiser, and I agree with them. But as long as we did all the work and we could share it with you, however, I think you should still, each individual or a solo physicist, if you're not academic, you should do these tests, and you should come up with your own way of having the confidence of the system. And one of the examples it comes often is the head and neck. Sometimes you start the patient, and all of a sudden 10 days later you have a reduction in tissue, which is about 2 cm from the skin. So then, so how do we need to re-CT? Do we need to redo the plan? So one easy way to do it, if you know and confidence, if you cone beam CT and you have a conversion table, and you have measured the HU units, you could quickly fuse the cone beam CT with the original CT, and you could then take the fields and calculate, and you could see the difference. And you could, you worry about, for example, lens, you worry about the cord, the most important thing. And also the coverage. You don't want to sacrifice the coverage to the BTP, because it's completely chunk and it's completely different and smaller. And so to do that with confidence, you need to do these tests. And now, of course, you have adaptive radiotherapy, and everybody is talking about it. You have a cone beam CT, you have a CT, a unit that is capable of getting a very nice, very comparable. There's hardly 1%, 2% difference between it and the diagnostic CT. So we getting better and better. But however, the complexity of a QA and the responsibility of the physicist is getting tougher and tougher, because the more complex the technology is, the harder on the physicist is going to be. And it is your sole responsibility. This is our oath. We have to make sure that what is the intention or what is the physician ordered is delivered. And that's one of the things that I was talking about. Or so when you do, like a prostate, for example, so you have a generic, most people just say, okay, we'll expand by 7 millimeter all around, except from the rectum side, we'll do 5. Okay, that's great. But if you have this technology, the whole thing is ALARA principle. So can I, using this technology, is there any way I could have the confidence of reducing this margin into 5, 5, and 3? And so it's not a very easy yes or no, but you have to do your due diligence, and then you have to come up, yes, you can, or no, you cannot. And all that depends on the machine itself, all the QA, all the TG142, and the task, and this task group that we have done here, and see if you have the total confidence, then you could say to the physician, yes, we could do that. Now, as you know, SBRT prostate is becoming more common. SBRT period is going to very soon replace everything we know how. And the whole thing depends on smaller margin around the BTV. But to do that, you have to have these tools that we are talking about. That's what's given us the advantage. Can we do it with confidence? And if we can, we can, but we have to do all this proper thing that I'm showing you. And you have to do it yourself. Every physicist needs to test that because that's part of our jobs. So again, we have elected machine, and so it is you have a mega voltage imaging system, which is called iView, and then you have kilovoltage, which is the XVI, and it's everything is mounted on the gantry, and you have the ability to do a 3D reconstruction. As a matter of fact, it also does 4D now. So that which is for SBRT, this is fantastic. Also for DIBH breast, that is very helpful. So you have many systems around, and each one has its pros and cons. And but the main thing you have the manufacturer sometimes gets way ahead of the physicist or the WBM, and there was no communication between them. To me, I think before the product gets out to the field, it should be communicated with the physicist or WBM at least, so the physicist will have a chance to look at it, test it, and come up with a recommendation. So now we are in sort of in the United States, at least. You have to follow the recommendation of the machine manufacturer, but also we have to do our own due diligence according to WABM. And sometimes WABM is 2 to 3 years beyond because it's just too much work, and we don't, we're all too busy. And so I think we have to do better than that. So what we have here, we have a variant OPI, we have tomotherapy, we have CyberKnife, and then we have Brain Lab extract, which we do here too. And each one has its own way of doing imaging and fusion. So yeah, again, we have so many task group, more than these, but these are the main ones that have reference to some recommendation to how to use and what to do when you have discrepancies for our imaging. And but it wasn't like TG 142, for example, a very short paragraph about how to or the recommendation for these devices. So that's the rationale why we jumped and we hurried up and we did. And that's why I really I had 2 graduate students fully, design dedicated to this, so we'll come up with some kind of a recommendation. I will share some of that with you if I have time, but there is some of these tests that we came up with. It was very helpful in actually some of the tests we did. It's sort of like show you a trend, especially for the HU unit. There's degradation over time, so that's why we do calibration every month. But also it gives you a certain test. It'll give you degradation to the machine, to the XVI system itself, that it would alert the manufacturer engineer that they need to do something about it before it happened. But again, we don't have the luxury of time as a physicist, especially as a solo physicist, and that's what I think is very limited, and that's why the task group turned me down in adding all these tests. But anyway, so this is TG 142 recommendation. So and again, if you see, there is the recommendation is very limited, and it deviates from the expected, and so that's one of the things we notice, and it still goes on until today. Like I was talking from the beginning, there is a lag of time between the technology and between WBM coming up with a recommendation and a task group. I don't blame WBM, but I do blame the manufacturer. I think they need to involve us from the get-go about these kind of things. And if you are familiar with TG100, and that is where people should be very, very concerned about this. So then again, what is it? I mean, is the clinical practice accreditation and regulation, especially in the United States, to go through accreditation like EBEX or through ASTRO to be accredited for as a clinic. It is a very time consuming, and everybody should do it, and you'll be tested just like if you are going for the ABR exam for every aspect of the clinic, and they want to make sure that everything is done according to ASTRO recommendation and the WABM recommendation. So having these task groups and having these reports help the physicists come up or accelerate the accreditation process. And of course, for regulation purposes, if we want to do a bill for IGRT in the United States, any billing thing with any billing for the patient, it's a legal document. It's a legal thing that you have to prove to the government that it was done properly. And so it's not just for the heck of it. It is if you're going to do it, you're going to do it right, and it has to obey and it has to follow the regulation of the WABM and ASTRO, which represent the government. So again, we want to at least state the minimum acceptable standard for use in IGRT. Similar to ACR has the own accreditation, and ASTRO also have their own standard. And as a radiotherapy department, ASTRO is more appropriate for us because ACR is really for diagnostic. So again, this is a clinical recipe for the solo physicist, and I've been there, and it's very, very important to have the help, to have something you could depend on or recipe you could go and grab to achieve your goals. And then, as you're doing it, you're going to notice something that perhaps somebody else didn't notice. So that's part of what I have done before. And looking at this protocol that I did, I noticed that doing this test that very, very detailed, it gives you sort of like a trend to warn you that something wrong is happening, is going to happen soon. But anyway, and so who uses these? What's the intention or the intended users? Well, definitely the medical physicist. You have to have the right tools. Of course, you need to have the time and the procedure. Even though we have a procedure or we have a recommendation, but I think each department, depending about what they have, they need to do their own procedure, and they have to write it clearly so everybody knows their job. Administrators, they have to be aware if they want to use this technology to make money, but they have to also pay money to make sure that this is done correctly. And that obeys the accredited bodies and also the regulatory for the government.
Dr. Hassaan, you have 5 more minutes.
Yes, sorry. Okay, so again, so we did all we did, and we try to prioritize what's the most important thing to achieve the goal for, especially the solar physicists or the private clinics, to implement these technologies, but give them the confidence that what they're doing and everything they're doing is correct. And it will give them the help in hand without another body being there. All right. So who is responsible for the staff responsibility? Everybody in the department. Radiation therapy department is very, very unique discipline. And you have so many different disciplines come together and to do a job. And the job is to make sure that the patient is getting treated correctly and within 2%, I hope. I know we have 5%, but I think 2% is what we're striving for. So therefore, a physicist cannot do everything. So it starts with the radiation oncologist, of course, the medical physicist, the dosimetrist, and then the radiation therapist. On a daily basis, they have to do to make sure that when they do the QA, the tolerances that we set for them, it's absolutely correct. And so whether we could use it today or we cannot use it today, it depends about this recommendation we set forward. Everybody again, so the responsibility, you have to train your medical physicist because again, they are the main principal body in any QA in the department. They are the driving force to reproduce or to give the most accurate result for treating a patient. It is again, when you get anything with a new technology, performance acceptance, and that's where I think performance acceptance is mainly coming from the manufacturer, which I think it's half right. We need AABM need to interject, and they need to give some guidance to what should be accepted. And just like buying a machine, I am very adamant about writing my own specs for the manufacturer. So when they come and we do our testing, acceptance testing, we go by my rules, not their rules, because I follow AABM to the T. And that way, in the future, if something happened, you are protected. And you are not going to sign on something just because they said, oh, this is the way we do it. So just a simple example, the flatness. I do flatness at 5 and 10 and sometimes Dmax, and I look at all, and I want to make sure that it's performing well. I don't want it just to be flat at 10 and the rest of it is going to be very crappy. Yeah, so again, not every patient is IGRT qualified. So the physician need to understand that they manage the physician procedure, they look at it, they approve it.
Yes.
It has to be reviewed before yes. I'm sorry, I'm getting
1 more minute. Yes.
I'm sorry.
Wrap up.
And again, the same medical dosimetrists, they need to know what to send to the therapy unit, so they will do the fusion. The therapists need to understand what they're looking at. And I'm just going to give you one quick example. So in my department, I did something very important. So if I have a prostate, I have a sample. They could just click in and see what is required, what is the best way to achieve a goal for imaging, and it will give you the energy. It will give you it is a bone or is it a gray. It will do that for lung, for head and neck, all this kind of things. So that is the kind of things that is very important that we know and we need to do. Then just very simple. This is part of the test that let's see. When I told you I did the 40 months of testing, so all these data that you see and we are recommended came from our institution, and we show we showed, again, you showed the variation for different material and how the HU unit changes over time, and with different energy, with all these kind of things. So
Yeah.
I think that's enough.
Yes.
Sorry, I have many more, but I'll stop here.
Thank you, Dr. Hassaan, for your informative presentation. We now go to the second presentation. If you unshare your presentation, and we let Dr. Sudesh Deshpande, who is Chief Medical Physicist at Hinduja National Hospital and Research Center in Mumbai, India. He has more than 25 years of experience in this field. He worked at many hospitals in India, and his areas of interest, including advancement of techniques in IMRT, SBRT, and also he has more than 25 publications, and he is a member of many local and regional organizations. Today, he's going to talk about patient-specific quality assurance in IMRT treatment. So, Dr. Sudesh, you can share your screen, and yeah, can you share your screen?
Yeah.
Okay, good.
Can you see?
Yes, just yeah, this. Yeah, we can see that. Yes,
Yeah.
good.
Good afternoon, good evening. Thanks for giving the opportunity to share our experience of 20-25 years, what we learned during our IMRT QAs in this last 25 years. I know most of the people who had joined us, they are doing the patient-specific QA. It is just a revision, and it is just a sharing the experience, how we do a patient-specific QA, what should we do, what should we not miss during our QA. So we know that the IMRT has a higher complexity in the planning, calculations, and delivery as compared to 3D CRT. We deliver the IMRT doses by calculating the beamlets. In other way, we divide the large field into small fields of very small fields of very intensities. We call them as a beamlets. Because the dimension of these beamlets are very, very small as compared to the reference condition, the electronic equilibrium is not achieved, and there are a lot of issues. There are a lot of issues in the calculations, and then that has been very, very well reported. We know that these varying intensity beamlets are delivered using the MLC with the different speeds, and this different intensities are delivered with the MLC, and we use then to deliver this intensity, we used to have a gantry rotation, or we used to create in a static gantry rotation, and we used to achieve the desirable dose distribution. What are the challenges? Everybody knows that we have a lot of challenges when we deliver the IMRT. Let me clarify. When I speak about the IMRT, it consists of the static field as well as the gantry rotation. That is, in other words, what we call as a VMAT, or the trade name called as a rapid arc. So when I thought about the IMRT, it includes the both things. We know that we have very complex fluence patterns. We generate this complex fluence pattern to get a good dose distribution. We want to take the more dose to the PTV. We want to restrict the doses to the OAR. So we require the complex fluence patterns. We know that we have very steep dose gradient, and the steep dose gradient we require because to achieve our goals of the OARs. So when we have this steep dose gradient, we have the challenges in our IMRT QA. For example, placing accurately our ion chambers when we do a patient-specific QA. We have very small field segments. So when we have a very small field segments, then we have another issue: selection of the chambers, then the accuracy of our treatment planning system to calculate the small fields dosimetry. We have the physical restriction on the machine side. For example, we have the MLC speed, we have the accuracy of the gantry speed. We have to check all this in MLC parameters. Then another challenge, it used to be a long time back about the accuracy of the treatment planning system, but most of the treatment planning system now has been evolved. Most of them are using the Monte Carlo base or convolution algorithm or model based, where the accuracy of treatment planning we have reached to the level. Then again, the question comes, why we require the patient pre-treatment IMRT patient-specific QA? What is the rationale behind doing the patient-specific QA? We know that there are many accidents reported. We in a US news journals, there are many countries where there is a system where people reports, the institution reports their errors in their calculations and all this. And we have found out that there are many things. There are scope for improvement in our patient delivery when we use the IMRT and all this thing. We know that there is a standard practice. When we do a simple 3D CRT plans, we do a manual calculations, and that manual calculation gives the confidence to the physicist that whatever the planning system has calculated the dose or MUs, we verify by doing the manual calculation. There are different ways to do a manual for the 3D CRT. Some people use the Excel. Some people have developed their own small treatment planning system like the things by entering just our PDD and output factor, and we do a validation of most of our 3D CRT plans. Why we do the patient-specific way? We want to validate the dose distribution. Since we do not able to do a simple MU check, so we want to do the dose distribution, validate the dose distribution. Assessment of the plan derivative. Whatever the complex MLC shape is there, what is the gantry rotation is there, whether we can deliver on the patient. So before delivering the plan on the patient directly, we want to see whether all the complexity of the treatment is achievable. Then minimizing the treatment errors. There is a possibility that when we transfer the treatment plan from the treatment planning system to the machine, there is a chances that when we transfer them, and there is chances of the loss of data or some malfunctioning of the data. So we don't want that to happen to the patients. And the important thing is the compliance with the regulatory standards. There are many countries there is a compliance. For example, in our country, in India, it is compliance to do a patient-specific QA. It is from the regulatory bodies. So that is another reason why we do a patient-specific QA. Okay, that is very important. What should be the goal of your personal patient-specific QA? One is to identify and resolve any error before it reaches to the patients. So we should have a system. We should have a system where we were able to identify that error and resolve that error before it reaches to the patient treatment. The importance of the patient-specific QA lies in the ability to detect and correct the errors. So the important thing whenever the physicists do a patient-specific QA, that QA system should be able to detect the errors. If our patient-specific QA system or the process is such that we cannot detect the error, and we see that okay, for a namesake or for a compliance sake, we do a patient-specific QA and our QA always passes, that doesn't make any sense. So to have a good IMRT patient-specific QA, we should have a good equipments for the patient-specific QA. For example, the sensitivity of our detectors. If our detectors, the 2D detectors resolution is not sufficient to get a good result, then we will always have a gamma passing ratio of 95%. But many times we may miss our errors, or if you are not using the sufficiently sufficient volume of ion chamber, or if your ion chambers are larger as compared to the desired volume, then also there is a good chances that the detector will not measure the errors or cannot find the errors. So the important thing for any patient-specific QA is that what system you are using, whether your system is sufficient sensitive to detect the error. And that is the main task of the medical physicist when we do a patient-specific QA. Selection of the correct equipment, selection of the correct process, and that process we should able to detect the errors. That should be our aim of the patient, not only for regulatory compliance or not for just for a namesake, we are doing the patient-specific QA, and we are getting our errors are within the acceptable limits. That should not be our goal when we do a patient-specific QA. Okay. Oh, generally, what we do, we have a treatment planning system. We do a plan. Then that plan is transferred to the treatment delivery systems. And when we transfer this treatment delivery system, before treating to the patient, we do a IMRT QA. We have the IMRT QA equipments. It may be the ion chamber arrays, 2D arrays or 3D arrays. Here we do a point dose measurement. And this, then once this, we do a QA analysis. This QA analysis is done by the medical physicist. When QA pass, we send it back to the treatment delivery for the patient treatment, and when QA fails, we do a root cause analysis. This is a general procedure. So when we do a patient-specific QA, it's not only the transfer of the plan to the machine and the measurement of that machine of that plan. For getting a good result of your patient-specific QA, there are two important things. It's all not only the IMRT QA equipment or IMRT procedure. There are two important things what matters your QA results. The one important thing is your treatment planning system configuration. This is the very, very, very important things to get your QA results good. So these are the some recommended from the AABMP. When you do a commissioning for the treatment planning system, that system we are going to use for IMRT or SBRT or VMAT, we should verify the small field PDDs, because we know that our bimlets are very small. So we should know we should use the 2x2 field size PDD, less than 2x2 centimeter PDD, and that PDD. So when we start using the small field sizes, the selection of the detector is very important. So that we have to do the more precaution when we select the small field sizes. Then we have to also verify the output for the small MLC fields. So these are there are some standard publications are available, and that if you use that publication and compare your results of your small field output factors, and if you are matching the published results or we are within the acceptable limit of that published result, then you have done a good job for your small output factors. Then we have AABMP task group 119, where they had defined the 5 tests of the different organs. For example, head and neck, then there are the prostate, mod prostate test, then there are some C-shape heart. Then you have to plan with the constraint what they are defined in the task group 119 and do a quality assurance, define your confidence limit in your department, and compare your result with the published result of the task group 119. If your results are within that acceptable limit or within that published limit, so you will get a more chance, you will get a more confidence that you have not done any error for that test. Then before starting the patients on the you should do some clinical test when we are starting a new system, when we are going for a new patient-specific QA system, or you have installed a new machine. It's always better to have some clinical test, do a patients, then verify before you start the patient. Then in most, you can do an external review, you can do an external audit, but these systems are not available in all the part of the world. So if you have a system where we can do an external review, we can do an external audit, that will give the extra confidence for a medical physicist. So this is the very, very important step when we do any IMRT commissioning. And again, the patient-specific QA results mainly depend upon how you have configured your treatment planning system. Okay, the second part in that system, what I had shown is the treatment delivery system. We do a daily QA where we have the monthly QA, we have the yearly QA, where we do a output characteristic check, we do a symmetry check. But to take a good results of your IMRT patients, we had to thoroughly do a MLC QA, what is defined in AABMP task group 142. And there are some publications, for example, for RapidR, there are some certain publications from the Clifton Link where they had given some standardized shapes of the MLC with a different gantry speed and a different MU. And that we had to perform before starting the machine for use of the patient. And if you are happy with this result, then only your patient-specific QA results will be within the acceptable limit. So this is the important thing before we use any institute to start the IMRT or VMAT clinically in their department. Okay. Most of the time, how we do a patient-specific QA. Once our radiation oncologist plan is approved, plan parameters are copied to a phantom, which is we generally called as a verification plan. Again, these plan parameters are copied most of the time, or 99% of the time, on a homogeneous phantoms. We do not consider any inhomogeneity during our plan verification. Plan is recalculated on the phantom geometry. So when we do a recalculation, we use the same algorithm what we had used during our planning of the patient. So if we are in the same planning system, we are using the same algorithm configure algorithm, there are minimum chances that we can find out any error during our patient-specific QA about the small errors about our configuration error in our TPS. What generally we do a field-by-field verification, means most of the times people used to follow that they will expose the beam, all the IMRT beam with a gantry 0, table 0, and collimator 0, and the position. Or now once the technology started improving, different detectors have come. Now people are started using the composite verification plan, created the composite verification plan where the beam angles remain the same, and even sometimes when we do the SBRT plans, even we don't change the table rotation, couch rotation also. Then we expose the calculated dose to our QA equipments. This is how generally we make the plan for a patient-specific quality assurance. Okay, now we have recently in 2018, we have the AABMP task group 218, where they had systematically defined how we should do the QA, how we should analyze the QA, what are the things we should look when we do a QA. So they had defined the 3 methods for the measurement methods. One is the true composite. The true composite method simulates the treatment delivery to the patient. The radiation beams are delivered to a stationary measurement device or a phantom under the couch using the actual treatment parameter for the patient, including MU, gantry, collimator, couch angle, jaws, MLC, lift position step. So this is, for me, I think if possible, or it is always highly recommended that we should use the true composite method for our patient-specific QA, because in this method, we are simulating the exact treatment of the patient. So whether is there any gantry rotation when gantry is at 90 to 70, whether the MLC are exerting any gravitational force, so whether there is any problem in the MLC moment when they are moving against the gravity, when with the gravity. So all these errors can be catched only once we have the true composite method. Then there are other two methods where we can do a perpendicular field-by-field method. This we used to do in 2003 to 2005, where the things were not that much available in the market. But when we started IMRT, we used to do this field-by-field method in 2003, 2005. Even then we moved to perpendicular composite method. Instead of measuring the single field, we used to do a composite of the field. We will expose the field, all the 7, 8 IMRT field in a single plan, and we'll analyze the composite dose. Sorry. These two methods has a lot of limitations, and it is not recommended at this era or at this stage that we should follow this method. The true composite method is ideal, and it should be used when we do a patient-specific QA. Okay. In patient-specific tube, generally we do a point dose measurement and 2D dose, 2D dose comparison. We know that ion chamber is the best fitted things for any point dose measurement. So we use the calibrated ion chambers. Size of the ion chamber should be small enough to avoid the dose heterogeneity. Nobody will define you what should be the volume. I'll also mention here the small enough. What do you mean by small enough? That is the decision of the medical physicist. When we do a small SRS, SRT, definitely we should use the pinpoint chamber. When we are doing the VMAT for head and neck or the prostate, we use the 0.13 chamber. There are no guidelines which chamber we should use. There is no guideline, but the chamber should be sufficiently, should not have any volume averaging effect. So we have to select a chamber such that there is no volume averaging effect. And then when we use the small chambers, we have to be very, very much ensure about the positioning of the chamber. What generally we do, what generally we should do, whenever we get a new phantom or new chamber for measurement, we should put the chamber in a phantom and do a CT scan. And we should not believe on what the marking the vendor has put, that we have reached to the chamber has put in a proper position and all this thing. What we do, whenever we get a new system, do a CT scan. CT scan, the 3D information will help us to know the exactly position of the chamber, whether the chamber is correctly positioned, whether the chamber has some issues. When we do a CT scan of the chamber, we know that whether the central electrode is properly placed and all this thing. Then avoid the high Z electrode. Initially, when we use the small pinpoint chamber, the electrode were from the high Z material. They used to be a steel. Now the things had improved. And then leakage should be 5% when you use the small or pinpoint chamber. Okay, these are some ideas about what chamber we should use for a point dosimetry. Again, this is well documented in many publications. But again, the choice, it's all about the choice of the physicist. And it's all what the plan you have. According to that, you have to take a decision and select your proper ion chamber. Okay. Now, this about the chamber. Again, the placement of the chamber is very, very important. The chamber should be placed in a region with the uniform dose and should not have an adequate spatial resolution. Okay. So we have to find we have to find a proper place we have to take one horizontal profile and find out what is the profile looks in the PTV area, whether there is any sharp gradient. If we have any sharp gradient, the chamber should not be at the isocenter. If we have the gradient at the isocenter. So this is what we have to learn before we do a patient-specific QA measurement. It should not happen that our result fails. Then we go back to the treatment planning system. Then we see why there was a variation. Then we come to know, oh, we are not placed the chamber at the correct position. There where we had put the chamber at the isocenter position, there was a steep gradient, and that's why our result may have bit failed. So before going to a failed result, we should do some homework prior to one day. When we do a plan approval, when we make verification plan, just see where is your chamber you had placed. Another important thing, what we had to see whether it is the uniform dose. What do you mean by uniform dose? So what we had done in our department, instead of measuring the point dose, we measured the mean dose of the chamber received. So we had marked the volume of the chamber in our treatment planning systems, and we calculate the mean dose and we compare that mean dose with our measured dose. So what we follow in our department, that the ionization chamber, our treatment planning should not show the variation of more than 5% from the mean dose of that chamber. What is the dose that chamber has received? So many people had different rules and regulation about the selecting the homogeneous area. This is what we follow. This is what it is written in the literature. In some of the literature, we may have copied their ideas, but this is a good idea we followed, and this has worked very well in our department. What we do in point dose verification, we measure the dose at the known condition. Why we measure the dose before starting any known condition, that is at 10 by 10 centimeter at reference SSD? This is just to verify that our setup is correctly done. Because, for example, last Saturday when we did a QA, I got a dose of 4.36 10 raised to power minus nanocoulomb, for example. So today also I should get the same dose. If I before starting my measurement, if I do such variation, such measurement, and if there is no variation in my 10 by 10 or my reference dose, this gives me confidence that my output has not been changed. My patient-specific QA instrument, what we had aligned today, is perfectly matched, and that's why this gives me the startup point. Okay, my setup is good. So when we do a measurement dose, we do the measurement dose at point of the IMRT plan. We compare that measured dose with the IMRT calculated dose, and we see that what is the difference there, and what is the acceptable limit of your institute, or what is the acceptable limit when been specified in your country. If we are done, we are happy with that. So what
Yes,
we should...
Sudesh, you have 2 more minutes.
Oh, I will complete.
Yeah.
Minimize. We have to minimize the error by using the small volumes of the ion chamber, calculating dose in the TPS, avoid the measurement area with the large dose gradient. We have different dose, 2D and 3D dose distribution. We have different detectors, films, diode, arrays, ion chambers, and EPID. Films are the gold standard. So the general rule is that we should do the commissioning with the film, and then we should move from the 2D array to the 3D array. We have different 2D arrays available in the market. There are some, they are using the ion chambers, there are some are using the diode. When we use the 2D array, we should always think about what is the angular response when we use them for a VMAT like cases. So we should know what is the VMAT, what is the angular response of particular chamber. We have 3D arrays in the market, and they works very well, and they does not require any angular dependence correction. We have TG218 recommendations about the global normalization. When we do whether we should use global normalization and local normalization. Yes, we should, for a daily purpose, daily things, we should use the global normalization. For a commissioning, we should go for a local normalization. What are the tolerances limits defined in the TG218? We should know that what is the action limit and what is the tolerance limit. Always we should be in a good tolerance limit of 95% and 3% 2 mm. But if you are not in a tolerance limit for sometimes, if you are in the action limit, that should not be worried for some few patients. That time we should see our dose distribution. We should see where gamma is not passing. Okay, this is very important things. I will just spend 1 more minute here. The gamma distribution should not carefully reviewed rather than relying only on the statistical evolution. We should not only believe that my gamma is 95%, I am happy. No, we should not know. We should know what is your maximum, what is your mean, what is the minimum, what is the median. That will give the result about your overall patient-specific QA procedure. And analysis of the maximum value percentage point that exceeds the gamma value of 1 point should be performed. Why it has been gone to 1.5% is very important. This is all about what it is written in the thing. Also, as a physicist, we should analyze the trends of the patient-specific QA results. Whatever the QA results I am doing, that should be analyzed in a 3 monthly basis or 6 monthly basis. How we can do it? We can do a site-wise, planner-wise, equipment-wise. For example, it may possible that your gamma might be passing for a head and neck with a 95%, maybe for prostate or maybe some SBRT spine, it may be for. So we should know what is the trends, we should for site-wise. Then it may possible that some planners, they do a very complex plan where they put a lot of constraints, their gamma might be failing equipment-wise and all these things. So as a physicist, it's not your duty to perform the QA, but you should analyze and you should know where we are failing. Where we can go wrong, this is all where we can go wrong. For example, we can go to the phantom device setup, beam characteristic, MLC, all these things can go wrong. The simple thing, what we do in our department, we do a reference measurement at 10 by 10 field size. So that gives the setup confidence about the setup of our phantom. The second important thing, what we do, we have one patient which has been passed with the 97% of the gamma, which is the head and neck patient. So before starting the patient specific QA, we expose that patient. And once with that same patient, we know that the last week the gamma was 97% with the same plan. So we expect that the gamma should be around 97% of the, if we start with that, then we know that there is no problem in the today's MLC error. There is no problem in our output factors, output of the machine. So we start. So still, if there is some problem in the plan, we check the complexity of the plan and we try to do reevaluate. There are different things. I will just keep it. AI is going to come in the patient-specific QA. It will take time, but definitely it will start predicting the scene by watching your complexity of the plan, and that will be the future for our patient-specific QA. Conclusion: TPS commissioning, MLC QA, choice of patient-specific QA is very important. Learning from the patient-specific QA results trend will improve your process of the QA process. Thank you. Sorry, I was a little bit fast.
No problem. Thank you very much, Dr. Sudesh, for this very clinical setup and information about QA. And also thank you, Hassaan, for your presentation. So I have only two quick questions. The first one is for Hassaan. What do you recommend for a physicist with the limited resources to use as a good and affordable imaging technique in clinical treatment? Like, for example, a physicist has very limited resources to buy equipment or to buy the latest machines. What is the minimum affordable imaging technique you recommend to use to give a good clinical outcome? Based on your experience.
So every manufacturer send you Phantom themselves. I mean, at minimum, they should use that. It has many inserts with different densities, and if they do that, I think it's fine. Anybody has any more question? I know we don't have time. They could write me, and I could provide to them specific procedures and techniques that they're welcome to it. I will email them to them.
Good. That's good. So also I have a question for Dr. Sudesh. We have a colleague is asking that gamma analysis has been reported to only weakly correlate to clinical significant error. Why is it still largely adopted, and what should be the future direction for gamma analysis?
Yeah, I know the gamma analysis is very weakly related to clinical results. That's why people are moving for the DVH based analysis. So there are many systems available in the market. There are, I'm not propagating some companies and all this. We have the 3D DVH from the Sun Nuclear, where we do a measurement. Then from that measurement, we have the algorithm where we calculate the DVH with what they had measured. And definitely that gives the more information when your QA results fails, and
right.
that is going to be definitely a future for in another 5 years where we will not rely only on the gamma values. We'll see how this gamma has changed our dose distribution. Definitely that is the future.
Thank you very much. Thank you, both of you. And because of limited time, so as mentioned also before, so if you have any questions, any concerns about these presentations, please feel free to send your questions directly to Hassaan and to Sudesh, and they will be very happy to answer your concerns. And finally, I would like to thank you all for attending this session. I know it is a summer vacation to most of you. I myself on my summer vacation, but still we are having like 1 hour of learning activity for everyone. Thank you very much again, and have a